Let's talk about opioids. Now, I know everyone in medicine thinks they know how opioids work. You learned about them in medical school, you prescribe them in the hospital or in the outpatient setting. You hear about them constantly in discussions about pain management and addiction. But let me ask you this. If I were to give you a blank sheet of paper and ask you to explain in detail how opioids relieve pain, not just that they bind to opioid receptors, but mechanistically what they do, could you confidently walk me through their effects at the spinal cord, the brainstem, the peripheral nervous system, and how each location might contribute to their analgesic properties? Could you explain perhaps why some opioids cause euphoria, while some are more prone to cause constipation, while others make patients feel awful or down? If any of these questions gave you pause for a second, then I want you to watch this lecture. By the end of this, you should have the answer to some of these questions, and you won't just be able to say opioids relieve pain because they bind to the receptor. You should say where they work, how they cause a change in nociceptive processing or signaling, and perhaps why they behave differently depending on the opioid receptors they affect. So first off, what exactly is an opioid? So most people would say like it's a painkiller, something like that, but obviously that's not the actual definition. So an opioid is any molecule that can be like natural, synthetic, semi-synthetic, that binds to opioid receptors. And here's why that's important. It means that even things like opioid antagonists like naloxone are also technically opioids. I mean, they bind to the receptor even though they don't activate them. So, and while we're here, let's clear up some terminology mistakes that I see. So, some people say like, oh, they're on an opiate. So, opiates, they refer specifically to natural compounds from the opium poppy. Think like morphine or codeine. Opioid is the more broad term, so that includes the synthetic, semi-synthetic drugs like fentanyl, oxycodone, methadone, things like that. And another term you might hear is a narcotic. The patient's on a narcotic medication. So it's kind of, it's meant to just say that it's a substance that can cause sedation or make people feel sleepy, but it's almost become like a legal term that has no real pharmacologic meaning. It gets thrown around by lawmakers to describe anything from like heroin to cocaine. So let's ask ourselves, how do opioids work? So opioids work by binding to G-protein coupled receptors. And if you remember anything from med school about G-protein coupled receptors, they work through secondary messenger cascades. So don't think about it as in like a vague G-protein coupled receptor inhibition kind of thing. I want you to understand what happens when an opioid molecule binds to its receptors. So looking at like a primary nociceptor, one of the first steps in pain signaling. So there's a nociceptor firing an action potential because you like slammed your finger in a car door. The signal travels up the axon towards the dorsal horn of the spinal cord, and there it's supposed to release this excitatory neurotransmitter like a glutamate or substance P, and that goes on to the secondary nerve in the signaling cascade. But if an opioid is present, here's what happens. So the presynaptic terminal, the opioid receptor activation inhibits voltage-gated calcium channels. So this means that there's less calcium flowing into the cell, and calcium's important for getting these vesicles to bind to the membrane and release these neuropeptides. At the postsynaptic neuron, so an opioid receptor activation leads to opening of potassium channels, and this hyperpolarizes the neuron, meaning it's less likely to carry on that pain signaling cascade. So that's the first way that opioids relieve pain. They prevent pain transmission at the spinal cord level, but it doesn't stop there. The brain has a built-in descending pain modulation system, and opioids affect this as well. So, here are the key players of this descending pain modulation system. So you have the periaqueductal gray matter. So this is kind of like the command center for descending inhibition. You also have parts of the medulla, like the rostroventromedial medulla, and this is like one of the relay stations. And then you have the termination point, the spinal cord dorsal horn. So this is where some of the pain modulation occurs as well. So in some of these higher brain centers, you have these inhibitory interneurons. This is going to get a little confusing, but so inhibitory interneurons that constantly leak out some GABAergic signaling onto this descending inhibitory pathway. So this is almost like putting brakes on this descending inhibitory pathway. So what opioids can do is they can actually bind to these descending inhibitory interneurons, and they kind of ease up the pressure on the brakes. So now the descending inhibitory system is able to signal a little bit more. It can have more of an effect on the dorsal horn and make it less likely for these pain signals to be communicated up towards the brain. So this is a table that represents how some of these receptors might provide analgesia, or some of the sites that they might act on to cause analgesia. And then down below in the bottom part of the table, you can see which receptors might contribute more to certain side effects. Like mu receptors are going to cause respiratory depression because of their actions on the pre-Botzinger complex. A lot of these receptors can cause issues with GI motility. Euphoria is caused by binding of mu receptors, whereas dysphoria is caused by binding of kappa receptors. Now, I think it's good to know this information because certain opioids have a predilection for different receptors. Buprenorphine is a partial mu agonist. Morphine is non-selective, and so depending on the opioids and their affinity for certain receptors, their side effect profiles might vary. Alright, so at this point we've covered how opioids relieve pain at the spinal, supraspinal, peripheral levels, but as y'all know, opioids are not selective in their effects. I know you're familiar with a lot of the textbook lists of opioid side effects, but I want to break them down a little bit. So, in the central nervous system, breathing is driven by chemosensitivity to carbon dioxide, in part. So the brainstem, specifically the pre-Botzinger complex in the medulla, contains neurons that act like a built-in respiratory metronome. So they fire to drive inhalation. Now, normally, if CO2 levels rise, then this respiratory pacemaker fires a little bit more rapidly, and it triggers deeper, faster breaths to compensate. But when you introduce a mu opioid agonist, you start to suppress the firing rate of this pre-Botzinger complex. And so that means when CO2 levels start to rise, the brainstem doesn't respond appropriately. So your ventilation is effectively blunted. And if the dose is high enough, then you can actually cause cessation of breathing entirely. And that's one of the biggest concerns with opioid analgesics is the respiratory suppression, which can lead to overdose-related deaths. So this effect can be dose-dependent, meaning the more opioid you give to a patient, the more likely they are to have respiratory suppression, and that's true for most opioids. Opioid-naive patients are the most vulnerable to that since they don't have a tolerance built up to that effect. Patients with underlying pulmonary disease like COPD, obesity, hypoventilation syndrome, obstructive sleep apnea, they can be at higher risk for some of these respiratory side effects. And that's also why we avoid, to the best of our ability, combining medications like benzodiazepines and muscle relaxants with opioids, because they can synergistically work together to suppress the respiratory drive and increase the risk of respiratory complications for patients. Nausea is one of the more underappreciated opioid side effects. So if you ask some patients why they dislike opioids, or if you look in their allergy list, nausea is often a common complaint, in addition to sedation or constipation. So opioids can actually cause nausea through a couple different pathways, but one of them is through direct chemoreceptor trigger zone activation. So this is an area in the medulla. It's rich in dopamine and serotonin and also opioid receptors. Opioids generally have minimal direct effects on the heart and the cardiovascular system. They can cause a decrease in heart rate and a decrease in sympathetic tone. A lot of the times blood pressure is maintained, but if a patient's already hypotensive or they're hypovolemic, sometimes it can exacerbate this. There are some oddities with specific opioids. They might cause actually anticholinergic properties. It might increase the heart rate, or they could prolong the QTC, but we can cover those in other videos. There are a lot of opioid receptors distributed throughout the gastrointestinal system. And so this can, when opioids act on these receptors, they can lead to side effects like in the stomach. They can increase tone, change rhythmic contractions of the stomach. They can decrease acid secretion in the stomach. In the small intestines, they can lead to spasms and increase the resting tone. And of course, infamously, opioids can lead to constipation. So in the large intestines, they decrease propulsive peristaltic waves, they increase tone, and there's increased water absorption out of the stool, which leads to hard stool balls and the constipation that patients often complain of. One of the classic things is in overdose situations, people will say a patient has pinpoint pupils. And that's just from pupillary constriction. Opioids can act on mu and kappa receptors in the ocular motor nucleus to lead to pupillary contraction. Opioids can cause a lot of changes in the neuroendocrine system, so they can impact things like testosterone, estrogen, LH, GRH, DHEA, adrenocorticotropin, corticotropin releasing hormone, cortisol. These changes can impact the way our patients feel, so they can lead to sexual dysfunction, depression, fatigue, dysmenorrhea. They can potentially impact bone mineral density, so they can have a wide range of effects on the neuroendocrine system. And then one of the last systems I'm going to talk about is the immune system. So exogenous opioids can impact the immune system in a number of ways. So they can affect phagocytosis, natural killer cell activities, cytokine release, cellular immunity, antibody effects. So to summarize, opioids are very powerful medications, and one of the more commonly used medications in medicine, I would argue. They're neuromodulators. They can interact with our body in multiple ways. Their effects depend on the receptor location and concentration, so they can have spinal, supraspinal, peripheral effects. Their side effects can be related to the receptors that they act on or they primarily target. Future therapies might try and target one specific receptor over another. And you can see some of the unique opioids that we already use in clinical medicine, like buprenorphine, which actually has antagonistic properties at kappa and delta, and partial agonism at the mu receptor. And so it's got a unique side effect profile, or I would argue an improved side effect profile compared to a lot of the other opioids. And then opioid therapy is not like a set and forget treatment. There are significant complications or long-term changes that can occur with chronic opioid therapy. So it's always important when you see patients in clinic or in the hospital to be considering some of the changes that occur with opioid use and chronic opioid therapy.